Dr. Khalifeh again. We're going to inject today the infraorbital fold. So we can see just a little bit of hollowing here. I'm marking the outlines. I like to, whenever I get close to the eye, I actually like Restylane, the plain Restylane. Nice filler. It seems to have the right consistency, the right degree of softness and ability to spring out the skin. So that's what we're going to do around the eyes. I'm going to inject, my plan is about 0.3. We're going to use a cannula rather than a needle. Anytime I get close to the eye, I prefer to switch to a cannula to avoid any major risks that can happen if a needle is used. And we're going to, of course, do that on both sides. Just a few seconds on the difference between a cannula and a needle. Around vascular structures, I like to use a cannula. What's the difference? They look the same from far. Can you see? Maybe hard to see, but a needle has sharp points. A needle has cutting edges. That's designed to obviously go through the skin, but we inject many areas with a needle, but that can cut through a vessel, whereas the cannula, and I'm not going to touch the tip because I don't want to contaminate it, but the cannula is a soft tip. It's soft and round. There's no cutting edges. So this will not even go through the skin. I have to use the needle to go through the skin and then use the hole of the needle to pop through. And I can be working in an area safely with a much reduced risk of injuring any vessels. Okay, so now we're going to go to our patient. Like I said, the cannula cannot be used to enter the skin. So that part starts with a needle. Pop through the skin using the sharp edges. And just leave the needle there for a second to dilate the skin. And come up with the needle. You can barely see the hole, but it's there. Now I can pop through. All right, and now I'm going to softly advance into the area that I've marked. So now my tip is always here. Okay. All right, so now I'm in the groove. You can see my tip all the way to that groove. And the key thing here is finger control, very slow injections. This is probably the area that is easiest to get a visible lump, and that risk is much decreased when you avoid injecting a big lump of filler. So it's no magic here. If you inject very slowly, and if you move to different planes up and down, you'll spread the product evenly and minimize your risk of getting any lumps. If a lump is too close to the skin, it can also discolor the skin when the light shines on it. It's called the Tyndall effect. Now, it's important to realize if you're watching this video, you probably do too much research already. If you're a customer and watching this video, so you've probably read somewhere that fillers can be dissolved. That's only true to a certain point. There are medications to dissolve fillers, but by that time the filler's already intertwined with the tissues, so it's not Photoshop where you just do an undo button. And surprisingly, so now if you go back to the syringe, we've injected, all this time we've injected 0.2, that's 20% of this vial. So that's how slow the injection should be. And you can see me starting to go past. I'm popping past that white line and then withdrawing a little bit to be right there and smoothing out that junction. going to scrape close to the bone into that ligament and raise up the whole ligament. That part, you may have noticed our stoic patient wincing a little bit. That part is sensitive. I told her I'd charge her if she cries, and she can get it for free. Hey, you're laughing too. That's good. All right, and that's it for one side. One more push through that ligament. Raise it up, and I think that's good for today. And we're at 0.35. Our estimate was 0.3, so we're right there. Always best to undercorrect. You never want to shoot for a full correction with fillers. And I think we're at that point. Okay. So now I've injected the infraorbital groove. The purpose of this video is not really to demonstrate cheek injections, but since we're about to do it, I might as well add a few pointers there. We're going to just use 0.2 cc's to augment the zygoma area, and that's going to pull up on the skin even further. That goes well in conjunction with the tear trough filler. For this purpose, I'm using a needle, and we're going to go all the way down to the bone and feel the zygoma. As a safety, make sure we're not in a blood vessel, which we're not. And we're going to inject like a little. Now I'm using a very thick filler called RHA4 that's going to have a good support of the structures. So I would not use this filler to do what I did here. So, a mixture of fillers is our preferred approach. And one more time, 1, 2, and 3. Down to the bone. Aspirate, nothing there. A little bolus of filler. Good. That's all we're going to do. Just a little adjunct to our orbit to create a smooth transition. Now we've moved on to the next side. Again, you can see the depression here. Let me see. Go ahead, take off your arm. And you can see how that's been corrected on this side. Of course, it'll look better once we wash off the betadine. Same thing, we're going to use a cannula. So first I go in with the needle, let the needle dilate the skin a bit. Around the eye, we'll be using the long 25 gauge non-sharp cannula. And slides right in. And here we go again. Slow injection is the key. And pop. And into a pop. You may have even heard it in the video almost. It's so loud. Those pops are little membranes, and just ensure that we blend the filler to join those regions. Those grooves you see are separations. That is a separation between the orbital fat and the cheek fat. So we're trying to blend those two areas. Okay, now we're coming to the area that is a little sensitive. We're going to pop through that medial ligament. Here we go. Sorry. And again, here's the part our stoic patient does feel. And again, with a cannula, we know it's safe as long as you know your anatomy. And that should match the other side now with a nice correction. Okay. Now for our last move, we're going to put the 0.2 cc's. Again, we've moved back. We're using RHA4, one of the very nice thick fillers. The Luma is also good. And to the bone, press it down a little bit, and one more time. Okay, that's all we're gonna do for this area. Go ahead and hold pressure and ice for a few minutes. We're doing a comprehensive 3-tube rejuvenation. Our next step, we've already done the eyes and a drop in the cheeks. Our next step, we're gonna use the thicker filler that we talked about earlier and inject a little bit in the nasolabial folds, a little bit in the corner of the mouth here. I'm going to do that through a single port site using the cannula, 1, 2, and 3. And here we go, pop through the skin, leave it a second to dilate the skin. Now we're going to pop through that site and into the nasolabial fold. And see the point? I'm pushing up that nasolabial fold. Injection with the cannula. Sometimes in her case, the groove is very superficial, it's soft tissue. So in that case, I like to use a cannula. As we get older, sometimes the grooves gets deeper, and I like to use a needle straight down to the bone, but not necessary in younger patients. And at the same time of injection, I'm trying to physically push that groove outwards. And by now, there's some product in there, so it should be less and less sensitive for the patient. And so we're going to do here. I'm going to switch directions, use that same entrance site, and fill up this little, it doesn't quite have a marionette line, but let's say it's the early marionette area that we're filling. And this is also adding a little hydrating hyaluronic acid to a wide area of the skin. Okay, thanks. Again, going through the skin with the 25 gauge. Made a needle hole, and here we go through the needle hole, pushing against that soft tissue groove and pushing it out, both by injecting filler but also by physically Okay, now I'm going to switch fillers. I'm going to leave the cannula in so that we don't have to stick it again. Now we're reloading our guns.
Sorry.
You don't.
Just edit it out.
That's okay. You can keep it in the video. I just didn't inject while you smile. Be a moving target. Keep that gun analogy going. All right. Again, I'm pushing. I'm not going to overcorrect that. It looks weird when you overcorrect the nasolabial folds. This is the first time our patient today is getting fillers. She's actually a area renowned injector herself and decided to take the leap. All right, very good. And again, are you okay?
Mm-hmm.
Right, pop.
Mm-hmm.
Never fun.
Mm-hmm.
Pop. So one word of advice to injections: never rush. Many passes, small drops each time.